CVS hosted their Investor Day this week, Kevin. Did you have a
They
chance to
did.
tune in?
I did. It was enjoyable. Tuesday morning, we didn't get the invite to Hartford. They kicked off saying it was a hard ticket to get. Maybe next year we'll get a ticket.
Maybe next year. It's also not really like optimal timing to be traveling in the Northeast, and so
That's true. Yes, but
weather-wise.
nonetheless, yes. Um, so, but yeah, seemed like um, good attendance. Good session Tuesday morning. What was it? 4.5 hours long they recorded. And then I think they had some more breakout sessions afterwards and whatnot in person. But really good overview of the business, right?
Yeah, I think CVS is such a fascinating business because it is so diversified. Like it's sort of a throwback to I mean, it's all healthcare, but it's sort of a throwback to like the conglomerates of the 80s, like 70s and 80s.
For sure.
RJR Nabisco, where you have like all of these different businesses and they're centered around this theme of healthcare, but they could not be more different in most of the cases. They have
Yeah,
different margin profiles, different factors that are impacting them. One thing that I think is interesting about CVS is that they've collected this handful of assets, and each of those, lines of business has had a uniquely bad time recently in different ways. And so you
yep,
kind of just walk through it, and Aetna had really significant challenges, like every health insurer did with the medical trend. And
hmm
I thought that slide that they had on, executing on their recovery plans and the operating income improvement. I mean, it's just like almost a line straight up for Aetna because in
for sure.
2024 it was $307 million and this year it's pacing to be like 2.8 billion.
Totally.
Um,
I
and
mean,
then
it's
yeah,
yeah. It's. I think Aetna is a really good example of the simplification. Like as I think about my like the key takeaway from the day on the whole, I think Aetna is telling a really good story of getting back to the basics on all of that. Like you talked about the issues that the three businesses are facing and kind of the 100-year storm that they're all in that we've heard analysts referring to in other earnings calls. And like you go I went back a year in some of our other health tech nerds analysis, and it's fascinating to go back and look at even like the Wall Street Journal article from October 2024, where they're talking about the management team meeting with activist investors. They're talking about bringing a bank in, and they are questioning whether or not you need to break up all of these assets. Because to your point, like Aetna is not doing well. They missed the boat in 2024 in terms of particularly Medicare Advantage. Individual exchanges were doing really poorly. Um, the healthcare services business was not doing great. PBMs had a whole bunch of pricing questions. The retail business was not doing great, right? Like they were projecting at the time decreasing 5% ish, right? Like you had at the time all of these businesses facing a ton of headwinds, and you had Wall Street losing faith in the management team. Like there was an analyst quote from back a year ago that was investors have lost faith in management's ability to hit their forecasts. This is Raymond James analyst John Ransom. The strategy of putting all this stuff together can work. They just haven't managed to pull it off. And that was kind of the sentiment at the time, right? Like there were these slides talking about the unit economics of how much Aetna benefits CVS on the whole by bringing together all of these assets. And like we can talk about the theory of that all day long. It sounds great, integrating medical, pharmacy, et cetera. They try to do that at a really challenging time in the industry. It didn't work, regardless of whether or not the theory holds true. And at the time, they had a lot of really hard questions to face. And the new CEO, David Joyner, has taken kind of a back to the basics approach, right? You've got these assets, execute on them well. To your point on Aetna, get that thing going again. And the market seems to be reacting well. Like the stock is up 50% over the last year. You can't like if you're management team of Aetna, that's a really good signal that the market has regained its confidence in your ability to hit those numbers. Um, Thought it was interesting that they were up 2% on the session. Like to me, that was kind of as we'll get into in the various parts of the business. The session, I think, did a good job projecting confidence in the various parts of the business. Um, but it was nothing earth shattering, you know? Like I didn't walk away with a fundamentally different understanding of CVS or where they're headed than I had going in. Like they are executing on Aetna margin recovery, healthcare delivery getting back to break even, the PBM being best in class and navigating this tumult, and retail taking kind of a center stage piece again to the business.
I think that that was a great summary. And I think that to your point on it being a back to the basics approach, the reason why I think this investor day was so unsatisfying is that we get the strategy, we get the theory, we get why this should work. Like it's so compelling. You're like, oh
Mm-hmm.
yeah, there's three CVSs on the street outside of my house, like 1 mile apart. And it's like that's where I go get my vaccines and my prescriptions and everything. So it's like it's so compelling. And you're like, so okay, but are you executing on it or not?
Mm-hmm.
That's the question. And so I thought it would be good for us at this point to kind of go through the different lines of business, talk about
Yep.
what they're thinking about in terms of strategy, but really in terms of, it's an execution play at this point.
Mm-hmm.
Then we can flag some stuff that was interesting for us. Should we
Let's
start
do it.
with healthcare benefits?
We gotta. That's where they started. Let's start there. So I thought it was funny. So Steve Nelson, relatively new leader to Aetna and healthcare benefits division, and I appreciated his kind of intro preamble on on the history of Aetna and being named after Mount Etna, um, and kind of the symbolism of how they view Mount Etna as this uh, long-lasting thing that persists through a volcano erupting and so on and so forth, and kind of viewing insurance business as that's sort of a mentality as well, and picking up on this back to the basics themes. Like a lot of what I heard Steve saying was, we're getting the right leadership team in place. We're changing the culture here so that we can execute on being a good insurance business and get back to the margins that we expect it to be. I thought it was super interesting to hear him call out, like, is one example that I heard him give of the change they've made and what that's unlocked is the ability to forecast and bringing in new actuarial leadership and so on and so forth. And I can certainly appreciate that commentary. And it makes a ton of sense to me why you need the ability to forecast. I think it also probably highlights some, like when Steve talks about the management change needed, the cultural change. Like if you're an insurance business, there's kind of a like you have one job, and that one job is forecasting medical trend well, right? And like if you need to like rethink that core competency, it's a signal you had big issues, and it's also a signal going forward though of I think that you should be confident that they're going to hit these numbers, right? Like I listen to Steve and I'm like, I believe him. He's going to hit these numbers, you know?
Yeah, I chuckled during that section because again, it's like this is your job, and you're like we're gonna really nail it this time, and you're like okay,
Mm-hmm.
like in fairness, it was a tough few years to forecast medical trend,
For sure.
and you think about the acquisition of Aetna and then like the lifespan of that, it was not an easy time to guess what was going on, but. Yeah, you really have to nail that, and we'll talk a little bit. They're forecasting an MBR next year of 90.5%, which is I assume like it's kind of our first indication is what medical spend is going to look like next year, and it's another hot year.
Yeah, for sure. I it very much to me was a as I heard Steve talking about it, like I think a quote I wrote down from him during the day. Strong first year in multi-year journey to recover at the margins. 2026 will be another strong step forward, right? Like it is still not going to be where they want it to be, but it is moving in the right direction. I think like if we go business by business for a second, like Medicare Advantage heading back towards the margin that they expect, which is 3 to 4% margins. That's kind of standard across industry. Steve, I thought did a good job explaining kind of the basics on how they win. Right, strong stars performance. this is one of the interesting intersection points to me in the business still that they called out a couple of times, which is they seem to be performing well on stars because of that retail capability that they have. And Martin, you've talked a little bit about like the weighting of pharmacy scores and stars, and that theory. It seems like it's an example of where the theory should hold. Of you have the pharmacy assets in the local market, you can have touch points with people in those pharmacies, and that should lead to better stars performance, right?
Yeah. There's also, I think, just a degree to which like having integrated medical and pharmacy benefits, just having the data in the same room, because the three star measures that are triple weighted are medication adherence performance or medication adherence rates. And so for, a handful of disease states. And the thing you have to do is make sure people pick up their prescriptions. And if you own a retail pharmacy, that is your job is making sure people pick up their prescriptions. So it's not that surprising to me that Aetna and United, who are the two MA players with a integrated PBM and like pharmacy benefit plan have, better star scores than the folks who don't.
Yep.
And Clover, who does not have an integrated pharmacy benefit, they really got hurt on their medication adherence scores. It's just when it's not inside the house, it's hard to keep your eye on the ball. You know, your doctor's prescribing something, but someone's not picking it up. There's not really a good data feed for that. But if you own the
Yep.
retail pharmacy, the prescription's just sitting there. So,
Yep. Yeah, it's fascinating. One of the other things I thought was interesting in the Medicare Advantage commentary, an analyst asked the question towards the end, if margin improvement is weighted specifically towards group, individual, duals, kind of opening the door to talk about what everybody seems to be talking about duals as an opportunity. Um, and the answer was very much it's kind of broad across the board. The margin is most heavily weighted towards individual, just given the size of the individual book of the business relative to everywhere else. But they are seeing improvement across the board, which I thought was an interesting response that they didn't pick up dual specifically. I also thought one of the other interesting things on Medicare Advantage was if you're on slide 14, which is where they're talking about kind of what they're doing in MA, they talk about strong value-based care partnerships. And I will be curious to keep an eye on what that means for them moving forward. In the analyst Q&A, one of the other things they mentioned in terms of managing trend was a rationalization of VBC partners and getting the right level of risk to the right partner, which conceptually again makes a ton of sense. Like as a payer working with those providers, you should want to do that. And as we'll get into in a little bit after we go through Medicaid and commercial quick, they are up to some really interesting activities in total cost of care management. And so I think that'll be an interesting element to keep an eye on for the business on the whole.
yeah. And that's been a theme across payers, right? And MA
For sure.
payers is like the heady days of V28 are over, and we're not just throwing global cap contracts at, wherever we can. And so, not surprising to hear that. A good indication that they have their arms around the problem is interesting in the context of the health services stuff, which we'll talk about in a minute.
For sure.
Medicaid, nothing earth-shattering here. They are seeing low single-digit margins for next year, which is right in line with what everyone else is seeing. They expect to do 20 billion in revenue, and they emphasize that their Medicaid business unlocks duals for them. And that's another thing that we hear is it's a tough time to be in the Medicaid business, but duals is strategic, and so we're gonna tough it out with these tough years in Medicaid so that we can work on this duals business, which is attractive.
It was kind of fascinating to me to see the Louisiana news about Medicaid kind of contemporaneous with this investor session. Like I haven't I'm even looking at the news as we get they pulled the contracts for United and Aetna, but now it seems like they're actually I'm reading something that they pulled back their plan to cancel Aetna's contracts. So it's not I'm just I think it's indicative of why Medicaid is kind of moving to footnote status in this. It's a business they want to be in viewpoint for duals, but like there's no analyst questions on Medicaid. It is not the central thrust of what's going on for CVS in 2026.
I think if you can manage your Medicaid business
Hmm.
sufficiently well, I think that's going to be a theme across a lot of people who have a line in Medicaid. Is that we want to
For
be
sure.
here for the duals. Don't mess it up. Just don't blow up the book on
Totally.
accident. And
Yep.
then commercial.
Yeah. Commercial, it actually seemed like there is fairly good momentum. It came up in the Q&A that I thought was interesting, where Steve was talking about the organizational revitalization and how that led to contract wins, the Blue Shield of North Carolina, or the State Employee Health Plan of North Carolina, and gosh, what's the provider system? Advocate, was that the other one he mentioned as the
I
other
think so, yeah.
contract win? And so it seemed like they're seeing good performance in self-insured business that's doing well, offset by fully insured business headwinds. Like everybody's seeing that kind of general dynamic. Um, uh, so it seems like going generally well. 30 billion in revenue, trying to keep margin consistent. Makes sense.
Yeah.
Anything else you'd add on commercial? I mean, I didn't seem.
No. I
Yeah,
mean, so I think this ties into what we're going to talk about next in the healthcare benefits business, which is they talked about some total cost of care solutions and their care management solutions. I thought this stuff was really interesting. Um, to number one, hear them call out autism spectrum disorder, saying like we've got a total cost of care solution. That's obviously been
for
top
sure.
of mind for every Medicaid plan all over the
Yes,
country, everywhere.
for sure. Yeah, I mean, so they talked about total cost of care management, and they're like they had four key pillars to success that they described: total cost of care management, transforming operating structure, provider experience, and member navigation and advocacy. Which, again, like building blocks of health plan, makes sense that they're targeting these things. Think they seem like the right things to be targeting. Uh, and it was fascinating to hear them talk about that total cost of care category in particular. They did give the example of autism, which they're like, hey, 460 billion of spend today. They talked about prevalence rates growing of that by 2028. It's going to be 600 billion of spend. And they talked about how they're implementing their solution. And like for me, it takes a second to think through like this is the benefits business. They have a care delivery business that is coming up next, and they are talking about what seems like a care delivery model, like a model for delivering autism care. And it's like, why are we talking about it here and not in care delivery? And then they go into what they're doing mechanistically, and it makes a ton more sense to me. What are they doing to manage total cost of care from autism? They are managing benefit design. They're changing that for their members. There's my thumbs up in the background. They are coordinating high quality providers, right? Like they're getting the network right. They are implementing an advocacy model to support members and navigating that network and everything going on. And importantly, they are integrating medical and pharmacy benefits, and they are coordinating across those two things. And that was one of the things that I heard in this section was that integration of medical and pharmacy. And logically, it makes sense to me. Like as we talk about these complex, high cost conditions with specialty medicines in particular, and they're talking about specialty meds, oncology, immunology, rare diseases, complex conditions, cardio, cancer, autoimmune. Look at the oncology market. All of that spend is being driven by drugs. It's not medical spend, it's drug spend, right? I mean, it's both, but it's primarily drug spend as I understand it. And so when you think about a plan trying to manage total cost of care, makes all the sense in the world to me that like, yeah, you manage both, you integrate both, you have an advocacy model that coordinates across that. Makes sense.
And on those high dollar drugs, what's interesting is that there's often some interplay between the pharmacy and medical benefit. And there's a
Mm-hmm.
huge advantage that they have because, you get something infused in a clinic and the drug is covered by the pharmacy benefit, but the person doing the infusion, that's the medical benefit. And so
Mm-hmm.
being able to coordinate that care is a huge
Mm.
competitive advantage compared to not a non-integrated system. The other thing I'll say is just as a piece of anecdata is that my family's on a self-funded plan that is administered by Aetna as a TPA. And we had a condition that was part of the like high dollar drug care navigation uh, navigation and advocacy piece, and it was really
Hmm.
good. We had a nurse assigned to us. She checked in on a regular basis. She was super responsive. Like, I think that very cynically, like when I hear someone being like, "Oh, we have like we're, welcoming and responsive and all these on your investor call," I'm like, "Oh, okay, but like, you're an insurance company." But they were really good, and it wasn't even their money. So
Good job, Edna.
yeah, I think that like
Yeah.
the healthcare benefits total cost of care solutions thing is like that makes sense to me as a service that as a value add service because it was really good.
Yep.
So yeah,
That's awesome to hear. I one of the last comment from me on the benefits business, one of the things they talked a bit about provider partnerships and the construct of what they're doing. And they made this comment a couple of times where Steve talked about the friction between payers and providers, and they need to fundamentally rethink that. And part of that transition is a transition from fee for service to value based care, and we'll get into that in the health services business as a segment. But I think that'll be an interesting concept to keep an eye on. Is how not surprising to anybody to hear them saying that there's friction between payers and providers, and that's at all-time highs, so on and so forth. But like, what are they going to do about that? A theme that I heard throughout the session, and in this part in particular, was how low trust is in healthcare at the moment, and how CVS on the whole is seeking to be the most trusted business in healthcare. And it's a great aspiration to have. It'll be interesting to see how they move towards achieving that over time. But I thought that commentary around the provider partnership model and then thinking about how they do that was particularly interesting.
they have a little bit of an unfair advantage in the trust category. Like I'm not surprised to hear them say trust, trust, trust. When you look
Mm-hmm.
at survey data, nurses and pharmacists always come in as the number one and two for most trusted people in healthcare.
Yep.
And they employ a lot of pharmacists and they talked a lot about nurses
Yeah,
on
for
this
sure.
call. So
Yep.
this is, I
I
guess, maybe the last thing I'll mention on the care coordination thing is they talked about sticking nurses in hospitals as sort of
mhm.
like for transitions of care. And we talk, in the tech world a lot about, okay, well, like AI is going to do this and AI is going to do this. And it's very interesting to see the recently capital disciplined CVS putting human beings in a hospital that they do not own just to manage transitions of care. Like,
Yeah, yeah. Again, like it's to me in some way, it's just like it's basic blocking and tackling, right? Like
yeah.
it's yeah, go coordinate transitions of care, and that is the way you help manage healthcare spend better. It's uh yeah, it's interesting. Healthcare services, should we get into that?
Yeah, I
Healthcare
think.
service, good.
Oh, I was going to just ask you quickly. So, one of the things I was thinking about Oak Street and Signify,
Mm-hmm.
and a theme that we've talked about is strategic business decisions that were made in a pre V28 world that were
Mm-hmm.
like tuned very well to optimizing for risk adjustment that have now sort of that's like not shaked out the way that they'd hoped. And I was thinking about this. Oak Street and Signify are two pretty good examples of that. So Signify is,
For sure.
doing screenings at home, and that used to be mostly that's like increasingly come under scrutiny as a risk adjustment strategy that CMS doesn't want anymore.
Mm-hmm.
And Oak Street was not totally premised on risk adjustment scores, but I was going back and reading your very good note on the Oak Street thing, and it was like, this is well tuned to capturing risk adjustment.
For sure. I mean, it's if you go back in time and look at how all of this played out, it's a fascinating journey just to map all the data points, right? Back, I forget the year specifically that Amazon bought One Medical, but if you go back and if you read the transaction timeline that gets filed with the SEC, it was clear that CVS was in conversation to buy One Medical too. Like they were the counterparty that was also bidding on the transaction, and that was publicly reported at the time. And notably, One Medical had acquired Iora Health, which was Oak Street's big competitor in the Medicare Advantage space. And the push at the time was, how do you get into primary care? CVS, what are you doing not buying that asset and letting Amazon swoop in at the last minute and take it from you? Seemed like largely over like some relatively minor valuation things if you believed in it. And the market was really pushing CVS to make a move at the time. They had to do something. And Oak Street's kind of the crown jewel of the Medicare Advantage primary care, advanced primary care model. And so CVS went out and bought Oak Street at the premium they did. What was it, $10 billion at the time ish?
I think you did the math and it was like 60 million a clinic.
Yeah, I mean, they paid a premium for Oak Street at the time, and at the time, if you go back and you look at their previous analyst days, there was a really compelling story that Wall Street was really excited about the synergy potential when you could grow your Medicare Advantage book of business on the insurance side and grow your VBC global cap risk bearing contracts and manage those betters with manage that population better with the pharmacy. And then, oh, by the way, you bring in Signify to do in-home visits to get all of those patients coded correctly, and off you go, right? Like that's a really, if you're a Wall Street equity analyst back in 2022, 2023, you're like, this is the model. Go do this. This is how you grow earnings. If you're an investor, this is where you're pushing CVS. And then to your point, all of a sudden CMS pulls the plug with V28 coming in. And like if you go back and read the transaction notes that I wrote about the deal back in 2023, this was the risk, right? The risk is that it was all funded by CMS paying more for this model. And when CMS turns off the spigot, guess what? The flywheel that's supporting it all reverses really fast and starts unwinding it all. And CVS has found itself in the middle of that unwinding. So you look at, you go back to the previous analyst days, they're talking about Oak Street having steady state margins in the teens, and now they're talking about that in the mid to high single digits, right? Which is it's reflective of the margin that CMS basically clawed back via V28 in the industry and the challenge that has come with that. Now, one of the things that is interesting to me, so as CVS is talking through the narrative in this investor day, right? The narrative as I hear it, hey, we're getting healthcare delivery. And by the way, pause for 1 second. Healthcare delivery is part of healthcare services, but it's actually a relatively small part of healthcare services, right? Like the big part of healthcare services is the PBM care mark. Like that is what is driving healthcare services as a segment. Care delivery just kind of sits underneath it too, I would presume, because they don't want to have it as its own reporting segment, which makes total sense. So we spend a lot of time talking about this like relatively small portion of healthcare services. Nonetheless, going back to kind of the narrative on it, if the focus is on getting healthcare delivery back to break even. Healthcare services as a segment is going to generate 7 billion plus based off the PBM, but delivery is just trying to get back to break even. They don't give a date for that. Like it's very clear they're on a journey back to break even, largely driven by Oak Street. They talk about the changes they're making for Oak Street in terms of scaling back the footprint, getting out of some practices that don't have the ability to get to profitability. But also they talk about driving revenue growth via increasing patient panels inside of practices without fixed costs. They talk about medical cost management. They talk about changing leadership team, technology, and operations, which, to be fair, is all of the things that you do to drive profitability improvements in practices like that. It also, though, is a really, back to the original point you were making, if that is all true, if that is what CVS needs to do to get to profitability, what does that say about the Oak Street narrative pre-acquisition, when the narrative for Oak Street, as I recall it, in advanced primary care is we have small patient panels that allows our docs to practice differently. We We have a new technology infrastructure that allows us to practice differently. We've revamped our operational infrastructure because we're VBC only. Like for them, for that to be the core narrative of the model, and then for CVS to be saying today, hey, we need to revamp operations. We need to grow our patient panels because we've got the opportunity to do that, and that is how we drive revenue growth and practices. We need to revamp operations and the leadership team. It's like, what what gives, you know? Like I get the narrative from startup land that like big corporations screw things up and they're bad and they suck and yada yada yada. And at the end of the day, they need to figure out how to get assets profitability because Wall Street demands that. And that's what's happening here. And I think a lot about like there were countless really good folks who went to work for Oak Street in advanced primary care models and were trying to build new versions of primary care. And it's like, I think it's really hard to grapple with like what what was the impact of all of that effort when we're sitting here in a post V28 world, and it largely just seems like a V28 driven mirage. I don't know. I'm going
But
to stop
like
rambling
it,
on Oak Street now.
if you want smaller panel size, you got to pay for it. Like people were
For
mad
sure.
about V28, and it was like the way you get small panel sizes is you risk adjust.
For sure. Yeah.
And
I mean,
like,
that like,
what do you want? Do you want lower long run American debt burden and Medicare solvency, or do you want smaller panel sizes?
for sure. I mean, this was, there was a Blue Cross in North Carolina article in Health Affairs, I think in 2019, that laid out exactly what has happened. Like they called it, this group. And what they said was this risk adjustment mechanism helps payers, it helps providers, and it helps patients. It is good for all of these stakeholders. It is bad for the federal government who is paying out more dollars in this form of risk adjustment, right? And like that played out over time, and we can debate the merits of it all and whatnot and whether that like how good of a thing that was, but it has played out to a T, and been fascinating to see. Can I the other going like getting back to investor day, so we don't talk about this for 3 hours because we could talk about this all day long. The notes on Oak Street performance that I thought were interesting in addition to that, one where they said, and we've heard this from Agilon also in the public markets, they're willing to walk from contracts with payers if they're underwater and can't figure out how to do that. I think that's going to be a really interesting thing to keep an eye on in 2026 in that negotiation between payers and providers. The last time we had data on Oak Street's contracts, Q3 2022, prior to the acquisition, Humana was the biggest partner for Oak Street at 31%. WellCare was the second biggest at 16. UHG was 10%. Presumably, those numbers came down and Aetna's come up over the last couple of years, but nonetheless, like it shows you who they're contracting with outside of Aetna. I would imagine they're not walking from their Aetna contracts because you'd think they would figure that out. So if they're talking about potentially walking, that'll be interesting to keep an eye on.
This is just to
But
bracket very quickly. This is like the shoe that I think we're all waiting to see if it drops. Is Humana going to get totally rolled by their provider contracts? And
yeah, I, I mean, we talked in Slack this week about there's the predictions article coming out that from Bob Kocher talking about Humana is going to collapse in 2026. I continue. I don't know. Either Humana is going to come out looking like geniuses, or 2026 is going to be really hard for them. We'll see
yeah,
for sure.
this is just like an interesting tie into that.
Totally.
What do you make of the Signify business these days?
It's you made the comment leading into the section about how CMS seems to be moving away from in-home assessments as part of the risk adjustment process. I would think that is a big headwind for Signify on the whole. They made the comment that the business is doing really well at the moment, and actually, like when Oak Street is seeing headwinds, Signify is offsetting that. So I don't know. What I thought was most interesting was they made the comment that Signify is adding in a second visit. It's not just doing the initial assessment, it's now doing a quality visit, which can either be a second visit or a standalone visit, but sounds designed to address gaps in care and close quality gaps. That is an interesting signal to me. Like if I'm I'm looking at managing labor profitably, adding a second visit into a business like Signify, particularly when your first visit is potentially at risk, makes a ton of sense to me. So I mean, I don't know. What do you think?
I think two things. Number one, I think Signify is a another example, if they're pulling it off and TBD, of this idea that you can sort of offer like quality management as a service.
Mm-hmm.
And there's other businesses like this. Like an example is Greater Good. They use nurse practitioners, but they charge PMPM and they're solely focused on closing gaps in care. Like that is the other thing. Like Stars competition is only getting more fierce. And if you have a machine, whether that is humans, Signify, Greater Good, or you have a computer program, which is what Clover
Mm-hmm.
says that they have, that can help you be more competitive in Stars, that's a valuable asset. The other
For
thing I'll
sure.
say is there's been some VC activity in the home modification space,
Mm-hmm.
and they talked a little bit about this in the context of Signify. No brainer. If you're in the duals business and you get people into the homes and you say, okay, we need a grab bar here, we need, like we're taking out the bath and we're putting in a shower, that
Yep.
is like your cohort performance is going to look really good in a couple years. So I
Yeah.
think it is not valuable maybe it's less valuable as a risk adjustment tool if Washington, DC gets
Yep.
there, but there is still value there.
For
Can,
sure.
can we talk about my favorite CVS business that no one else likes, which is the Minute Clinic?
Yes.
I love the Minute Clinic.
Why do you love it so much, Martin?
Well, like I said, it's like right across the street, and I use it for everything. I think it's great. I also think just intuitively, like when people were talking about this idea that it's like, oh, we're gonna put primary care in neighborhoods and communities, and Walgreens was talking about this, and CVS, and like the stat about how most people live however many miles away from a CVS or a Walgreens. It seems like it's like not a very good business, and no one else likes it as much as I do. I don't know what's going on. Like I just don't like it makes so much sense to me, but it's like it seems like it's perpetually struggling and perpetually a footnote, and I don't know. I don't get it.
Yeah, I think all of that makes a ton of sense. And it's been interesting to watch them over. So the big update I heard on Minute Clinic in this investor day was they're adding primary care capabilities in the Minute Clinic. They're up to 400 primary care clinics across the country. They made the footnote in that they're one of now largest primary care practices in the country as a result of that in Minute Clinics. They mentioned about like they're getting 15% of their patients that are in for acute stuff into that are selected for primary care Minute Clinic, which I thought was an interesting phrase to. I didn't quite understand what that meant. And that 60% of those patients are showing up for an annual wellness visit in 6 to 8 weeks. So, like, it does seem like they're driving some adoption of that and have rolled this out in a pretty meaningful way. CVS has gone after this in a couple of different ways over the year, right? Like, they 5 years ago had their health hub strategy, which was trying to build out primary care, advanced primary care capabilities in clinic. Um, they then added Oak Street in. They then went to a like, we're going to partner with Carbon Health to be infrastructure for our Minute clinics. And that seems to have gone by the wayside. So, like, to your point, there is a thesis here that makes a ton of sense to me. And I would not be surprised to see this footprint continue to evolve over time. I think the most interesting part of this to me is actually on the provider workforce side of the world. Like, to offer primary care in a Minute clinic, you have to have primary care providers who want to work in Minute clinics. And like, if you go back to the CVS Oak Street acquisition and look at like the communications that Oak Street sent out to its providers, a lot of it was like, you're not going to have to work in Minute clinics. Like, you're gonna continue working on Oak Street. Like, this is not Oak Street disappears in CVS. And to me, that is really telling of the provider supply side challenge of getting folks to work in Minute clinics. which I would guess is actually the bigger challenge for CVS than like you've got the footprint to your point. Like add on those services and maybe more technology changes that. I would assume this is where like NPs being able to practice by themselves in states and whatnot, like that only helps. So I agree very much in theory. From a consumer perspective, I think it makes all the sense in the world. From a healthcare econ perspective, I think that's where it's always gets hung up, right? Because like you can't get the providers in to grow it fast enough to make it meaningful for investors, and so it just kind of falls to the wayside. I don't know.
Yeah. There is just one more piece of anecdata from my own Aetna inside view is that a service that Aetna offers is a $0 copay uh, option for Minute Clinic. And
Mm-hmm.
so for both annual wellness visits, I mean, obviously annual wellness visits are always free, but for like coughs, colds, flu, like in
Yeah.
place of a teledoc thing. And so if
Yep.
you're a Aetna TPA, that's like a great offering. I don't know if people use
For
it.
sure.
I never used it,
For
but
sure. That I mean, I think that is telling in a lot of ways, right? Like the
I
theory
use
of
it for
it
other
makes
stuff, but I never
makes
used
all the
it for
sense in the
cough and
world.
cold. Okay.
Yes.
Let's talk about pharmacy services. Wow, 98% customer retention, 40% of the Fortune 100. Not bad. I think my favorite part of this presentation was when they were, starting to talk about the changes to the PBM, and they were like, many of your benefit managers came to us and told us.
Hmm.
So if you're mad, you should go, if you're mad at our changes to the PBM, you should go talk to your benefits manager.
Yep. I mean, that is the state of the world, right? Yeah, I mean it was a pretty full-throated defense of PBMs and the value that PBMs have. And like to be honest, I buy it. Like I'm listening to this and as I would articulate the narrative, and I am by no means the expert on PBMs and how price it like how this true cost is actually changing pricing. What it seems to me is pricing got all haywire over the last few years. Employers finally started getting mad about the lack of transparency and the markups and so on and so forth and how this rebate stuff works. And CVS said, "Hey, you know what? You want to see the true cost, the net cost that we see? We will show that to you, and stop taking margin on top of that, whatever, whatever." Okay, that generally makes sense to me, like price transparency for employers, so on and so forth. Um, and then CVS is like, here are all the things that we are still doing to actually manage costs for our employer base and negotiating on their behalf. And like they came back to this in the analyst Q&A, where one of the analysts, I think it was Lisa Gill, was asking CVS about D2C and pharma's and like pharma manufacturers going to direct consumers, bypassing PBMs, and like what's the role of Caremark in that future of care? And the point was a pretty frank D2C is more expensive than anything on the PBM. The sole reason why the PBM exists is to negotiate prices down on behalf of our employer customers, so on and so forth. That theory actually, like, I buy that. I think it's gotten very confusing over time in terms of like how that actually plays out. But as a theoretical starting point, okay, I'm there. But then where I get confused, and you could hear some analysts also asking this in the Q&A later on, is like, so how do you make money on the PBM if you're showing employer the acquisition cost of the drug and you're letting them buy it at the acquisition cost and you don't have a markup on top of that? Like how does the PBM grow? And I, in my mind, CVS didn't explain that all that well. Like the answer was kind of, well, it's growing. And I don't like they said, I think they got 4% margins historically on the business. They expect it to be at 4% margins. Like they're guiding to 7 billion a profit on this segment as a whole. So like clearly profits are there. I just, I don't like all of those levers are just confusing to me.
Yeah, I think that PBMs are one of those things that like breaks people's brains because
Yes.
it's confusing, but also because there's also like the pharma lobby. There's like, I get LinkedIn ads all of the time being like PBMs are trying to steal your
Yeah,
firstborn child.
for sure.
And
Nobody likes middlemen.
no one likes middlemen, but middlemen provide a valuable service, and that's why they're there.
For
And
sure.
someone should pay them for it. So I think that there was a it was on this CVS website when I was poking around yesterday. They talked about how, like, historically, the way that they would run the PBM business was a very complicated sort of cost shifting from some high dollar to they were running it's an insurance business. You are pooling risk. And so there's some drugs that are really expensive. There's some drugs that are cheaper. You're doing all of these complicated negotiations, and
Yeah.
you're taking a haircut on some drugs and getting some huge rebates on some others, and you're netting out to 4%. Now it seems like they're operating a services business. They get paid for negotiating, and no one is going to be materially better off in the true cost model, but people are going to feel better because they'll be able to see the prices.
For sure.
And it's like, I hope you're all happy, like, because now people on really high cost drugs are not going to benefit from the I mean, they will still benefit from like their employer will still pay for them, but it'll seem more expensive. You'll say, oh, Joe over in accounting is costing us all of this money instead of, oh, you throw it into the PBM machine and everyone pays this much. So
Yeah.
like my like hot take of the day is like PBMs are good and price transparency is net bad
Hmm.
because it just makes people on high cost dollar drugs get a target on their back.
For sure. I one of the more interesting points that they made that I think is going to be worth keeping an eye on over the next several years is it gets a little into specialty pharmacy, so I don't want to go too far into that, but it's um, as these new drugs come to market and they are complex um, drugs that need to be refrigerated and dosed in the right way and delivered in the right way, community pharmacies are not going to be able to handle that. And you are going to need the distribution capabilities of these organizations to actually provide the infrastructure to deliver these more complex medicines. And like it worries me to your point on PBMs being good. Like we've got states in this country who are, telling CVS and other PBMs to get out. You can't do both. I actually think there's a really good case for doing both in scenarios like that, which is like what people don't reckon. 5, 10 years from now, we're going to have scenarios where disparities are going to be getting worse because you don't actually have access to these sorts of drugs in these um, rural markets, et cetera, because like literally, like you can't figure out the logistics of refrigeration and dispensing of these drugs in various markets across the country. Like it's going to be wild to me. So to me, uh, everything's a pendulum, right? And we are clearly at a moment in time where PBMs have gotten on the wrong side of political crosshairs, and they're working through that. This seems like a good move in this direction. I thought it was interesting back on the like PBM part of the conversation at the investor day. They gave two, I think, good tangible examples of the role PBMs play. One was with it HIV prep drugs, where they're like, hey, PBMs couldn't negotiate prices anymore. That resulted in $1 billion of extra costs going to our clients because guess what happens when you don't have PBMs negotiating costs down? Pharma can then raise costs. Like pharma, I'm sure would argue the point back, and I like we don't need to get it, but conceptually, it does make sense to me what they are saying, and I am inclined to give them the benefit of the doubt when the theory makes sense to me. Um, they also talked about biosimilars and that opportunity over the coming years, and how much savings they are driving in the biosimilar market. And to me, that was kind of the general narrative of this PBM section. The true cost change is underway. We are going to that. We will still have margins. Biosimilars are going to be a huge opportunity for us over the coming years. And specialty pharmacy is also going to be a huge opportunity for us.
Let's talk about specialty pharmacy. This is, I think, one of the most, this is like maybe the most attractive business for if you're an investor and you're thinking like, oh, we're gonna crack open CVS and break it up. Like the specialty pharmacy business is kind of one of the crown jewels or was. And it's interesting to hear them talk about this specialty pharmacy business and what it provides because it's not just like, oh, we buy these high dollar drugs and then deliver them. It's the cold chain. It is the managing of, specialty drugs are not just specialty drugs because they're really expensive and require extra care and handling. They're also much more complicated regimens than just like take this pill every day.
Yeah, for sure. I mean, this
Injectables, infusibles, like this is serious infrastructure that you need. You can't just do it at your local well hub.
for sure. I mean, I so CVS is talking about this as one of their key growth pillars. They talk about how it's 2% of members who are using these drugs, but they are driving I forget the number they quoted, but high portion of drug spend in this country, 50% maybe, I think they quoted. This is going to be an ongoing topic of conversation. I mean, I conceptually understand why CVS is talking about it as a growth lever. Um, it that very much rings true. I think we'll be talking about it a lot more. Interestingly, like the slide, what was it, slide 45 in their investor presentation, they've got US specialty market revenue, product sales, 2028 in the US, they expect to be 425 billion, which I get we're all excited. Like specialty is growing and it's high cost drugs, and we need to manage those drugs, and so on and so forth. It's also interesting to me to compare 425 billion of specialty revenue in 2028. Go back to autism care market, which they're projecting medical costs associated with that at 600 billion in 2028. Like it's an interesting kind of market sizing exercise across those things. Like I would have expected, especially that like the number on the page there to be, I guess not an order of magnitude higher, but like bigger. I don't know.
Yes. I think some of that, though, to your point, is like it's 2% of the population. And so
Yeah, for
it's
sure.
like on a
Yep.
per dollar basis. But I guess yeah, I mean, the autism prevalence like 1 in 31, so it's sort of similar dynamics. But this is where we're
Yep.
at. I mean, this is like, to defend the spending, it's like once you solve the infectious disease stuff, you get to like solving the bigger problems with the more complicated stuff. And so
Hmm.
that's kind
Yep.
of where we're at. I had
My
a
my my last. I'm always a fan of looking at where the analyst questions come in as a signal of like what's going on in the business. There, I think, were 11 questions that were in the Q&A. Um, Five of them were on the PBM and talking about what revenue model is going forward across PBM and specialty and those dynamics. So, and I'm lumping specialty under PBM in that category. Uh, it is clear to me this is CVS's main thrust of the narrative over the next 3-year journey that they're setting up in this investor day, which again is, I think, just an interesting evolution on the market as a whole, where a lot of the narrative doesn't feel all that similar for CVS, but as compared to 3 years ago, as an example, where it was very much like integrated care delivery, insurance play with pharma as part of that, that has kind of done a 180, right? It is now PBM, specialty pharmacy, growth engine, key part of the business, things the analysts want to know about. There were two in questions about insurance trend and what's going on there, and one question on VBC. Like that whole narrative is flipped. Oh, and by the way, there were three questions on what's happening in retail and how CVS is growing in the retail business. So, like to me, it's very indicative of while the narrative is generally similar, while it's back to the basics in many ways. Getting back to the basics is acknowledging, hey, we have a huge PBM business, big specialty pharmacy opportunity. We've got our retail footprint. Aetna is there doing fine. So maybe should we get to retail now?
let's talk retail. Probably the most impressive part of the turnaround story. Like they were guiding to -5% growth and they maybe are going to hit flat. this year.
Hmm.
It's like pretty good, especially because people have been talking about the death of retail pharmacy for a while. I thought the first analyst question about retail pharmacy was a pretty good one, which was like, is this because you run the business well, or is this because Walgreens is failing and you bought Rite Aid's book?
Yeah.
Um,
I, I thought it was, I also noted that question too, where it's like, I appreciated the question because I think it's probably the question on everybody's mind. I also think it's indicative of the presentation, which, it talked a little bit about the actions. They're focused on the durability of the core business. They're implementing new technologies. Crazily, they talked about they now are on track for 500 million annual calls being handled by conversational AI, which, like, their general point is help pharmacists practice top of license in retail pharmacy, let them spend more time with patients, so on and so forth, which, like, back to our previous conversations, makes a ton of sense from a narrative perspective. But the fact that, like, your analysts are like, how did you do this is kind of indicative of it's a wild change. And back to your anecdata about being a customer of these products, like Walgreens is closer to me than CVS. And so when I need a script for kiddo or what have you, I historically go to Walgreens. I am so frustrated by the experience at Walgreens that I am like, every time I get a script filled these days because of, ear infections, whatnot, I'm like, I need to switch it to CVS and go there instead. But like CVS is just a little bit further away and my doc has Walgreens, so I don't do that. But like I can see enough people being like, I'm going to CVS now that that's the behavior that's driving this performance. I don't know.
I love a retail business in healthcare. I think like the because it ends up being one of these 3 yards in a cloud of dust, like execute the fundamentals
Mm-hmm.
stories. And I used to work for DaVita, and that's a company that's kind of famous for this, like, we're going to be maniacal about pushing costs down. And so it's been
Mm-hmm.
cool for me to watch this CVS story from the analyst side or from the earnings call side, and then go into the stores and see like one pharmacist and one pharmacy tech who are, just like it's like running around the back of the store, but doing a great job. One of the things that I thought was like an interest, so they're in a dominant position. Their front of store sales are recovering and doing better.
Mm-hmm.
Retail pharmacies historically not been a good business. You've relied on front of store sales to make up the margin. Um, they are forecasting almost 2 billion, 1.86 billion filled prescriptions in 2026, which is a lot. Um, and one of the things that I think is interesting as we think about this strategy that they have is, okay, you have, as a part of the rural health transformation program, pharmacists scope of practice is like a one of the criteria. And so a bunch of states have added pharmacist scope of practice as part of their rural health transformation program applications. And you were talking about how, PCPs maybe don't want to go work in pharmacies, but pharmacists don't mind working in pharmacies, and they
Mm-hmm.
do today. And they can do vaccines today. There's in some states there's a small number of prescriptions that they can prescribe, but this is one of those things where, like, if you have the asset and the regulations shift a little bit, it is a good store. It's a good place to be in.
I'm going to go on a total tangent for a second
Please
here
do.
because you just made me think of it. I've been listening to the Cheeky Pint with Eli Lilly's CEO podcast episode, and I'm going here because, like, as we're talking this through, I actually think I am getting my, like, in my head, I'm like, I'm really bullish on CVS right now. Like, and where I'm going, the Cheeky Pint episode, Eli Lilly's CEO is talking about how, this wave of drug innovation is coming down the pipe. They've got trials ongoing where they've got infusion treatments that are preventative for Alzheimer's, neurodegenerative disorders, stuff like that. They've got some sort of drug that could potentially just like cure high cholesterol. I might not get this 100% right, but like conceptually, that is what I am hearing him talk about on that episode. And it maps to my narrative, which is like the innovation in drugs is going to be a major part of the story in healthcare moving forward. And perhaps the most transformative part of healthcare over the next decade. Like we're going to see drugs that do things that we can't comprehend today. A organization that has the core assets of CVS between this footprint that exists in local markets, the pharmacists that you mentioned, and the capabilities across specialty pharma, PBM, like that's a really good place to be sitting strategically with where the industry is heading at the moment. And Aetna and the care delivery assets can play key parts of that too. And like you can talk about like back to that Signify point, like the in-home assets and things that you can do with things like that, particularly if you maybe do some bolt-on acquisitions around that over time, like that's a really compelling narrative. And, you know, I don't think you want to get over your skis too much in that future, but when you can talk about, hey, we're getting 13 to 15% growth in these core assets and have that narrative on the whole, that's really compelling. So I don't know. Sorry, that's the
No,
end of
no,
my
no.
tangent.
To build on that, there's a kind of quasi. So pharmacies have this problem everywhere in the world, right? It's like
Mm-hmm.
historically not been a great business to be and so I spent some time in France, and in France, like the money makers for pharmacies are they sell like lotions and like face creams and stuff like that. That's like because they can sell them tax free, and they get tourists. And like my sister came and she like had a haul. Um, and the French government was like, we are not wild about like French pharmacies going out of business, but they're this underutilized asset today. And so they did this experimental program where oral chemotherapies are a big thing right now. Used to be you'd go in, you get an infusion, and they were like, well, what if we could have pharmacists, like community pharmacists, manage oral chemotherapy treatments like out in the community? And like, oh, obviously that seems like a great idea. And you pay them like $50 a month per patient per month. It's a cool program. And you think about, the growth of these specialty drugs and even stuff like
Mm-hmm.
GLP-1 where you have symptoms and you're adjusting doses and stuff like that. It's like having a community pharmacist manage these things would be really valuable. The reimbursement models are not there yet, but if you happen to own a PBM and an insurance company or an MA plan, you don't really need you don't need to wait for the reimbursement models to get there. You can just go do it yourself.
Mm-hmm. For sure. Yeah. I mean, yeah. I think to me that is the core thrust of CVS exciting narrative, which maybe to get like the last core topic they talked about after. So we've gone through the core business updates, right? They had the healthcare benefits, healthcare services, and then pharmacy and consumer divisions, those three divisions. And then they spent some time talking about this engagement consumerism platformy thing, which like I almost wish they axed that section from the presentation. Like, w- as we just talked about, like there's a lot to be excited in that core narrative, executing on that core narrative. The engagement platform, it was kind of like it felt like their investor relations team felt like we need to like we can't just talk about how we're executing on the core businesses. We need something innovative to talk about here. And so we're going to announce the launchment of this engagement as a service integrated app model that somehow the industry is going to like all want to integrate into the platform because consumers are going to demand them to integrate, and they're launching it and they plan to monetize it, but it's not like no projections are actually included in their 3-year forecast, and they don't have anything real to announce, but they're in serious conversations for their founders circle members to join in 2026. I'm like, this just like strikes me as innovation theater, not to be too critical on that group. Like I'm sure there's a lot of folks working really hard and building a meaningful functionality app, but like it didn't feel ready for me to be on the main stage at Investor Day as like, hey, this is our innovation thrust. Like it talk about that when you've got some external partners who are actually paying for it in a meaningful way and contributing to double digit earnings growth, because that is the story you're telling to investors at the moment. So to me, that was like, it was a little underwhelming to end on that like engagement platform section. How'd you feel about it?
Yeah, it felt to me like in Clover earnings or on, like when they talk about the SaaS platform, and it's
Hmm.
like, or Oscar when they talk about the SaaS platform. I really like, it feels like a throwback to a different era in capital markets where of like the early 2020 era where everyone wanted a
Yeah,
SaaS thing and everyone loved SaaS. And we're just not there anymore. Like if you're in an insurance business, what I want you to do is care management. I want you to be really good at care management.
for sure.
I think that the engagement platform stuff is probably really useful from a care management perspective.
For
So
sure.
talk about that. Use it
Yeah.
internally. I
Yeah.
don't want to, yeah.
I like they talked about Oak Street being integrated into the app in 2026. And I'm just like what does that mean? Like I just don't understand it. So I don't know. They kind of lost me on their slides. They were talking about we're an AI first company, and I'm like, come on, guys. I know everybody's talking about AI. Like you talked earlier about how Aetna is named after Mount Etna and has been around hundreds of years. Like you're not an AI. I think it was AI native, actually, not AI first. Excuse me. You're not an AI. Like you are what you are. Do that really well. Don't sell me on this like app that like as a
Also, I don't want
customer.
my insurance.
Yeah,
I don't want
no.
my insurance to be amp. I want my insurance to be old and
Yeah,
risk averse and manage their money well. It's like
yeah,
the reason why banks are, sort of massive granite things. It's like you want to look at it and be like, oh, I trust that with my money. And it's like you look at Aetna and you say like, yes, I'm gonna trust that with my health, not like whiz bang. So yeah, I am with you on that. And I think that they're doing it well. And it's one of those things where it's like you don't have to talk about it because if you're
right,
doing it well, it is going to be clear in your execution.
right.
And I think they are doing it well. Like I am bullish on this. And so yeah, it also feels like the sort of like late hype cycle thing. I mean, I don't know if you've seen where Oracle's at right now, but
Mm-mm.
they are spending 15 billion more in capex than they said that they were, and
Mm.
they're down like 10 or 15% in the market.
Interesting.
And so I'm not calling like the top of the bubble for AI, but it's like once CVS is starting to say you're AI native, you should start kind of questioning where we are in the because it's like, no, you're a retail pharmacy and you're really good at it. And you're an insurance company and you're really
Yes.
good at it.
Yes. And automate your phone call trees with AI so that they are a better experience. Great. That does not make you an AI native company. Case in point, Martin, as a fan of the Minute Clinic experience and going and lauding your experience there, how many times do you log into the app?
I don't have it downloaded on my phone.
I like case in point. What are we doing here?
Yeah.
Um, I expected that answer. So yeah, I mean, I don't know. I think like tying it all back together, wrapping it up, despite the like underwhelming nature of the last part of the conversation, like go back to the beginning of where we started this. CVS a year ago was in a world of hurt. There were real questions, activist investors coming in saying, like, do you need to break up this business? Can you actually execute across these different capabilities? And to their credit, they've done a really good job getting back to the basics, recognizing where the market is at, and executing across that. So it's not surprising the stock's up 50%. Like, I've got a lot of more confidence in Aetna and where Aetna's headed and getting back to target margins. The PBM business seems like it's on the right track. Um, the specialty pharmacy business seems like a huge opportunity. And the retail business, as we've talked about, while it's not exactly clear how the ship has turned so quickly and if that is from CVS's intentional actions or other market retreats, it's a really good place to be given where the market's headed. And so none of this is investment advice, all those caveats, but like I'm pretty bullish on where CVS is going on the whole and their ability to get there, despite not being all that confident in the AI native consumer app side of the world. but like I don't think you need to buy that to believe in the thesis.
Yeah, I think to put a point on it, that analyst said from Raymond James said they have the assets. It should make sense. They're just not executing. And 2026, if they execute on it, is going to be
Hmm.
a really good data point that shows that it is possible for their theory of the case to win out. And if that's the case, then it's easy to imagine, you have CVS and you have United as like the two integrated healthcare companies who are able to take their assets and do interesting things with them.
For sure. Yep. All right. Well, that was a fun hour breaking down all all the various CVS businesses. It's interesting getting into these vertically integrated players with how much of the industry they touch. Because there's a lot to break down in it all.
Yeah.
But fun doing
This
it
is
with you.
great. Yep. All right. Have a great rest of your day.
See you later, Martin.